Hello, my name is Erin Allen, and I'm a certified athletic trainer. Today I'm going to present on human movement and basketball injuries and how they relate to one another. The biomechanics of the foot and ankle are a crucial component for normal functioning of the lower extremity. Abnormal mechanics of the foot and ankle cause a breakdown in the mechanics designed to distribute and dissipate normal forces that occur when weight bearing. Excessive or restricted motions within the ankle joint specifically reduce the ability of the foot to act as a shock absorber, a torque converter, adjust to ground surfaces, and provide an efficient lever for push-off during walking gait and running gait. When motion within the ankle joint changes, connective tissue and muscle function alters, which influences force distribution and movement patterns throughout the lower extremity. Inadequate force distribution can lead to abnormal amounts of stress being placed on joints not designed to dissipate the applied stress and eventually cause breakdown of connective tissue or muscles. There are several intrinsic and extrinsic factors that cause abnormal mechanics of the ankle that can lead to further injuries, and athletes can develop these dysfunctions over time or congenitally. Some examples of abnormal ankle mechanics or dysfunction that also include foot posturing include abnormal pronation, which results in an inability of the foot to effectively absorb weight-bearing forces, which is also considered pronation distortion syndrome, which is considered when the foot excessively pronates and the arch collapses inward. This causes the knee to produce a valgus movement, resulting in an inappropriate amount of stress at the knee. Another abnormal biomechanic of the ankle and foot is forefoot varus, which is the single most common intrinsic cause of mechanical pain and dysfunction within the foot, ankle, lower leg, and knee, influencing everything within the kinetic chain. Abnormal supination results in inability to pronate the foot, which can cause irritation within the foot, such as plantar fasciitis or Achilles tendonitis. And abnormal pronation and supination can indicate excessive or restricted motion within the foot and ankle, which will cause the athlete to develop compensatory patterns for the ankle to appropriately function during the gait cycle. And previous literature indicates that the majority of the time, compensation occurs at the subtalar joint and or the talocrural joint, indicating the need that abnormal biomechanics of the ankle influence everything up and down the kinetic chain, which is important that we address and recognize these abnormalities. Now, basketball requires players to jump, land, accelerate, cut, and change directions quickly and frequently throughout the game. And ankle plantar flexors are a substantial component that is responsible for absorbing these landing forces and also providing a smaller amount of dorsiflexion during landing, which results in greater peak landing forces. If less dorsiflexion displacement occurs during landing, then less knee flexion and hip flexion displacement also occurs. And when an athlete lands with restricted dorsiflexion range of motion within the ankle, they experience greater knee valgus displacement and posterior ground reaction forces compared to those with unrestricted dorsiflexion. Ultimately, limited dorsiflexion range of motion is a huge contributor to excessive knee valgus and is linked to harmful landing mechanics, which is an essential component of a basketball athlete. Deficits in ankle dorsiflexion occur as a result of tightness in the gastrocnemius and soleus complex and restricted posterior talar glide over the tibia during ankle dorsiflexion movement. When individuals lack appropriate motion, they develop compensatory patterns that may come from foot pronation, internal rotation of the tibia or hip adduction, or pelvic drop. All of these can contribute to valgus stress at the knee. Now, ankle biomechanics such as range of motion restrictions within the ankle joint can alter jumping mechanics and reduce jumping height. In fact, the degree of dorsiflexion and strength of plantar flexors are important contributors for shock absorption when landing from a jump. When this does not occur, the kinetic energy is improperly absorbed higher up the kinetic chain. Additionally, range of motion restrictions and dorsiflexion will alter jumping and landing mechanics, as the athlete will compensate at the trunk and with their position of their heel depending on the jump demands, which can place the athlete at risk of sustaining a lower extremity injury. Therefore, it is important to recognize and address range of motion restrictions in athletes, as they can have a negative effect on performance and increase the risk of injury. Athletes with poor ankle mobility will also display movement compensation patterns during various squat variations and change of direction movements, which increasing the forces placed at the proximal joints, particularly the knee, and predisposing the athlete to a non-contact knee injury. Additionally, ankle instability or restricted mobility can cause injuries at the ankles. Ankle injuries are the most common injuries in basketball, and approximately half of all ankle injuries sustained during basketball occur when the athlete is landing from a jump. Furthermore, about 1/3 of the injuries occur during a sharp cut or change of direction, and previous ankle injuries are a strong contributor to future ankle injuries as well, indicating that the influence of ankle mechanics can influence everything within the kinetic chain, starting from the ankle, knee, and increasing up towards the hip. Now, ankle sprains and lower extremity injuries can occur as a result of ankle dysfunction. And dysfunction can be displayed as instability or immobility. So some causes of ankle instability, there are two main types of instability, which are mechanical instability and functional instability. Mechanical instability is related to anatomical abnormalities within the ankle, which is usually related to ligament laxity or range of motion impairments of the tibio-tarsal joint, related to dorsiflexion range of motion deficits. Ankle instability can result from previous injury, but not always. Hyperlaxivity can exist within the ligaments, stabilizing the ankle, resulting in a lax or unstable ankle. Limitations in ankle dorsiflexion is considered an influential factor in ankle instability. In fact, individuals with tight or shortened gastrocnemius muscles reported overall ankle instability in 67% of patients and ankle instability in 25% of those patients. Now, functional instability includes the muscle structures and involves proprioception, an element of posture control throughout movement, essentially knowing your body's part in relation to one another. An example of functional instability may be hindfoot varus, which results in excessive pressure on the lateral edge of the foot, resulting in postural imbalances in single limb weight bearing. Now, to assess for ankle immobility or ankle mobility within our athletes, we can use two separate screening tools. A comprehensive movement assessment called the functional movement screen utilizes the overhead squat test, which is the first one here on the left side of the screen, which the overhead squat test is used to assess the athlete's movement at the ankles, knees, and hips through a squat movement pattern. To assess for dysfunction in ankle mobility, the athlete performs an overhead squat, and as they're performing this, we watch for excessive external rotation at the feet and or if their heels lift off the ground as they try to achieve a deeper squat. These are two compensation patterns that indicate poor ankle mobility, which will assist in determining the appropriate corrective strategies to address movement dysfunction at the ankles. Now, another assessment used to assess ankle dorsiflexion is the weight-bearing lunge test. An athlete places their foot with their heel and toe aligned on a tape measure. A vertical line is drawn on the wall in line with the tape measure. The athlete is instructed to lunge forward until their knee touches the wall. The heel must also remain in contact with the floor to test true ankle dorsiflexion. Then the clinician records the distance measured in centimeters, which allows you to convert to degrees of dorsiflexion to determine the amount of dorsiflexion the athletes have. So screening for this type of immobility can also be helpful if we recognize improper movement patterns but are not sure of where the mechanical chain is affected. So there are different strategies to eliminate ankle dorsiflexion. Reduce ankle dorsiflexion range of motion and ankle dysfunction may occur as a result of tight calf muscles, inherent ankle joint stiffness, or as a result of previous ankle sprains. So anterior cruciate ligament injuries and ankle sprains are one of the most common ligamentous injuries in basketball athletes that occur with a non-contact mechanism and are associated with the presence of ankle dysfunction. Therefore, we must address the underlying factors that contribute to ankle dysfunction, which is instability or restricted mobility. It is important to treat soft tissue limitations to reduce range of motion restrictions or dysfunction that occurs as a result of poor muscle extensibility. Foam rolling and stretching of the gastrocnemius, soleus, hamstrings, quadriceps, and overall lower extremity musculature is essential. Further, incorporating a dynamic warm-up that includes dynamic stretching is warranted as well in addressing the soft tissue limitations. And it was even found that basketball players who do not complete a general stretching program as part of their pregame warm-up were 2.6 times more likely to injure their ankle than a player who did include stretching. Now, increasing the plantar flexor extensibility and dorsiflexor range of motion is essential to ensure proper mechanics occur at the ankle joint. So other important strategies that you can utilize, performing a manual tibio-talar joint mobilization or mobilization with movement will improve the talar glide and ultimately the talar crural dorsiflexion, which is necessary in athletes who sustain chronic lateral ankle sprains or exhibit chronic ankle instability. Also, previous research found that incorporating balance and proprioception training will improve an athlete's ability to stabilize oneself, which is a risk factor for sustaining a non-contact injury and postural stability deficits during functional tasks, which also occurs as a result of dysfunction of compensatory movements when performing proprioceptive activities. We can increase our ability to process information and execute motor commands more efficiently with the proprioception exercise program. Implementing a balance training program to improve balance and reduce the number of recurrent ankle sprains, and ultimately reducing the risk of sustaining a non-contact ACL injury are also warranted to help eliminate ankle dorsiflexion. Now, some additional strategies as well. So, due to the influence of ankle dysfunction on the proximal joints, it's essential to implement strategies that address the specific ankle dysfunction in joints proximal and distal to the ankle. Implementing a strength training program that focuses on whole lower extremity strength and power, balance, proprioception, and improving biomechanics have been shown to prevent lower extremity musculoskeletal injuries and are necessary to recover from movement dysfunction. So if an athlete has very tight and limited dorsiflexion range of motion, and once we have improved that range of motion, it's important to reteach the mechanics of a squat or landing mechanics with their newfound motion, as they might not be able to know how to perform the movement correctly due to the compensation patterns they've exhibited prior. So there's also a significant relationship between hip abduction weakness on the involved side and chronic ankle sprains. So therefore, it's important to address glute med and general hip abduction strength included in their strength training programs to reduce the risk of ankle sprains and further dysfunction at the ankle joints as a means of implementing a comprehensive injury prevention program. Also, focusing on proper landing mechanics and movement patterns to ensure proper force absorption and ankle position occur during planned landings, which can inform proper movement patterns to be carried out into competition. And then correcting faulty movement patterns or impairments to help resolve these impairments and help decrease the risk of future injuries and enhancing athletic performance. So proper landing form and body movements decrease abnormal pronation or supination at the ankle, which ultimately influences the valgus stress at the knees and abduction and internal rotation at the hips. And will also decrease improper shock absorption and reducing the risk of non-contact injuries, so that's super important. And then, as I kind of mentioned before, the strongest predictor of sustaining an ankle injury is history of an ankle injury. So educating athletes about the benefits of rehabilitation following an initial ankle sprain to prevent further ankle or lower extremity injuries, and utilizing preventative measures such as taping or bracing to prevent ankle instability from causing further injuries is crucial in eliminating ankle dysfunction. And ensuring the athletes follow through with the rehabilitation program is imperative as well. And then one general strategy for eliminating ankle dorsiflexion and overall reducing the risk of injuries as a result of ankle dorsiflexion would be implementing a injury prevention protocol. An example here would be the FIFA 11 Plus as a warm-up program, which is efficient and effective in reducing injuries sustained in basketball and can help address poor movement patterns such as a result of muscle imbalances, instability, or joint dysfunction such as at the ankle. So those are a couple strategies there that can be helpful. Now, if we do not address the ankle dysfunction, we place our athletes at risk of sustaining further injuries. And these are just a couple that can occur, as I'm sure there are definitely more. So restricted dorsiflexion range of motion may cause an increase in ACL loading and injury risk due to compensation patterns, which include less knee flexion and greater knee valgus displacement and greater ground reaction forces when landing. So when an athlete displays greater passive dorsiflexion range of motion, they experience greater knee flexion, displacement, and reduce the ground reaction forces, which are all risk factors for sustaining a non-contact ACL injury. Modified lower extremity movement patterns or compensation patterns result in force placed elsewhere, which can contribute to an increased risk for ACL injuries or developing patellofemoral pain syndrome as the force dissipates higher up the kinetic chain. Also, restricted dorsiflexion range of motion is associated with a greater risk of sustaining a patellar tendon injury. So dysfunction at the ankle joint or ankle instability places an athlete at risk of sustaining a lateral or high ankle sprain during sport as well. Acute ankle sprains are known for their high reoccurrence rate, which is associated with the development of chronic ankle instability, which further contributes to ankle dysfunction and poor movement patterns. Now, depending on the ankle dysfunction displayed by the athlete, the ability to appropriately dissipate the weight-bearing forces will be hindered, such as in landing, cutting, and jumping, which can cause inflammation to develop within the foot and surrounding connective tissue, resulting in plantar fasciitis and Achilles tendonitis. And in fact, reduced ankle dorsiflexion is a reported risk factor associated with patellar tendinopathy, Achilles tendinopathy, chronic ankle instability, metatarsal stress fractures, plantar fasciitis, and anterior knee pain. And when an athlete exhibits an inability to achieve appropriate dorsiflexion, the joint reduces its contribution to force absorption when landing from a jump, which increases the load on the patellar tendon and places the knee at risk for patellar tendonitis or anterior knee pain. Therefore, it's essential to recognize dysfunction at the ankle to reduce the risk of sustaining athletic injuries and improving functional performance. So please feel free to contact me if you have any questions regarding injury prevention and addressing ankle dysfunction. Thank you for your time and attention, and here are some of my references that I used throughout my presentation. Thank you very much.